greatest lectures in the world. They don't have fun, pretty pictures, and we don't have any activities. So if you guys need a break, just let me know. We'll take breaks as we need to. This material is going to be really important. You're going to have a lot of patients that have cardiovascular issues. So a lot of these terms are terms that you are going to hear as you get into practice. Okay? All right, so starting first with cardiovascular disorders. So we're going to start chapter 14 first, and then we'll go back and do blood disorders for chapter 15. Okay? So cardiovascular first. So in general, you have a lot of really general signs and symptoms that somebody with cardiovascular disease may present with. And then as we go through the different conditions, we'll talk about some things that are going to be a little bit more specific. Okay? So in general, your general cardiovascular symptoms are going to include things like chest pain, edema, fever, circulation problems, breathing problems, bluish discoloration, fatigue, and also fainting. Okay, so those are, again, just really general common symptoms. When the heart isn't able to pump as much blood, the blood pressure is going to drop, and that is what would cause anybody to faint in those circumstances. Okay. Claudication. This is also really prominent, really common in this population. Claudication is going to present with very severe cramping of the lower extremities. Okay? There are a couple different types of claudication, which we'll talk more about in the future. But in general, this is going to be very commonly seen in walking or in exercise, which is then relieved with rest. Okay? When it comes to cardiovascular symptoms, there is also a common referral pattern. Okay? As you guys know, a lot of times people, when they're having a heart attack, will have left arm pain. Okay? So same thing, this could go up into the neck, into the jaw, into the upper back right left shoulder, and then down the left arm. Okay? Also breathing difficulties. Okay, these patients will often present with dyspnea, which is shortness of breath. Okay? Or orthopnea, which is where they will feel breathless while laying down, which is then alleviated when they're sitting upright. Okay? Next, we have different types of diagnostic tests. Okay? So again, even if you guys aren't necessarily running all of these tests, you need to be able to interpret them when you see the results in somebody's chart. Okay? So we're going to run through these first. So first we have the ECG. Okay, this is an electrocardiogram. So basically you have these little electrodes that are attached to a person's skin, and they're connected to a machine through wires, which will then transmit amplified electrical pulses from the heart, or impulses from the heart. Okay, so then you get the actual printout of what the heart rhythm looks like, and that is your electrocardiogram. Okay, so this is how doctors can diagnose things like arrhythmias, or look at heart attacks, etc. Okay. You'll also hear this called an EKG. So ECG, EKG, those are the same test. It's just a different acronym based on different spellings of the same term. So EKG is based on the German spelling of the term versus ECG, which would be our English term. Okay. We also have auscultation. So this is something that you guys can do, but we will not, interpret the results as well as a doctor would. Okay, but you guys will still practice this at some point. So auscultation, this is always going to be step number one when looking at somebody with a cardiovascular issue. Okay, so you're going to actually listen to the heart rhythm through a stethoscope and listen for any type of vascular abnormalities or heart murmurs. We also have stress test. Okay, this is something commonly done in physical therapy. Okay, so this is looking for more cardiac exercise-induced problems. Okay, so it's helpful in order to look at somebody's more functional capacity, and then the results from those types of tests can be used to then direct the rehab plan. Okay, so cardiac rehab is a specialized area of physical therapy that you guys can go into if you're interested. so that's where a lot of those types of stress tests would be done. Okay, next we have chest x-rays. So this is, you can actually look at the heart in terms of its size and shape with that. Cardiac catheterization. This is a very common procedure that you guys will hear about. So in order to do this, they basically take a catheter and they go through a blood vessel in the leg, most typically the femoral artery. You can also approach it through the upper extremity, through the radial artery. You just can't use as big of a cath with that because it's a smaller area. But they go from the extremity up into the heart ventricle in order to then assess its function. We also have coronary angiography. So these are angiograms where they still use a catheter, but the person is actually sedated, so they can inject a contrast. Okay, so they can look at video fluoroscopy and actually see how the blood is flowing and assess for any obstructions that way as well. Okay, Doppler ultrasound. This is another type of test that you might see. This is looking at the sounds of blood flow through high frequency sound waves. Okay? Blood tests are also going to be super important for this population. These are going to be used to look at serum triglyceride levels and cholesterol levels. And then specifically if somebody has a heart attack, they will show elevated levels of troponin in their blood as well. So that's basically just a cardiac enzyme, and that's a good marker of the presence of a heart attack. And then lastly here we have arterial blood gas. So this is used to assess oxygen levels, okay, carbon dioxide levels and acid-base levels, or pH. All right, one slide here on cardio rehab. So we already kind of mentioned that a little bit, but again, this is a cool area to go into if it's something that you're interested in. In general, there are 3 phases to cardiac rehab. You have phase 1 is inpatient. So here, this is going to be very low level for these patients. Sorry. So things like ankle pumps, gait training, a lot of education at this point, learning bed mobility, learning transfers. Phase 2, they progress to outpatient rehab. So here they have to be much more independent, right? They need to be able to self-monitor their cardiovascular status. They're working on more endurance training, higher level activity in outpatient. And then phase 3 is going to be after discharge. So basically discharging them to a home exercise program where they're fully capable of continuing their rehab independence. Okay, so next we are going to dive into the different pathologies for cardiovascular, okay? These can be divided into 2 big categories. So one being heart disease and the other being blood vessel disease. Okay, so basically looking at whether something affects the heart muscle itself or more just the peripheral vessels. Okay, so starting first with coronary artery disease, okay? So your coronary arteries are the arteries that actually supply the heart, okay? So in this condition, these arteries are going to get blocked by atherosclerosis, okay? Atherosclerosis is basically fat deposits or plaques that are now blocking the arteries, okay? So this can lead to temporary cardiac ischemia and eventually to a myocardial infarction. Okay, so in terms of your symptoms, the very first thing that somebody is going to present with is going to be angina. Right, so basically chest pain. Okay. Other symptoms could include more of burning, squeezing, or crushing feeling. And then again, it could take on that referral pattern that we mentioned earlier, either going up into the jaw or down into the left arm. Okay. Once it progresses to that point, that progression to a myocardial infarction, that's when you're actually going to be able to see it on an ECG. Okay, so for atherosclerosis, so like I just mentioned, this is basically plaque deposits in the coronary arteries. Okay, so you have what's called stable plaques, where those plaques become surrounded by fibrous tissue. Okay, and that's now going to lead to more permanent type changes. Okay, so atherosclerosis is a type of arteriosclerosis. Okay, arteriosclerosis is where the actual artery is going to become hardened. So there is a loss of elasticity in the blood vessels. Okay, that is going to result in an overall weakening of the heart muscle. It's going to lead to cardiac ischemia and then eventually to heart failure. Okay, so people with this are going to start exhibiting symptoms once the artery is about 3/4 occluded. Okay, so that gives you an idea of the severity of the condition at that point. Okay, when it comes to treatment for this, the main goal is to restore sufficient blood flow to the heart. Okay, that can be done simply through medication that will encourage vasodilation, or it could be done through different procedures. Okay, the most common procedure that you're going to see is called an angioplasty. Okay, this is used in order to open the constricted arteries. So basically, in order to accomplish this, they take a guide catheter and go through a peripheral artery. So similar before when we did the diagnostic test, they could go through the femoral artery or through the radial artery as well. They go up into the coronary artery, so wherever that blockage is present, and then they thread a balloon catheter through the same way into the area where the blockage is present. And then once it's placed, they inflate the balloon in order to move the plaque against the arterial wall and open up the space in the artery. Okay, so thereby increasing blood flow to the heart. Okay, so that is going to be one of the first types of treatment that they do. And if that fails, that's when they would go to advanced procedures, so something like a coronary artery bypass surgery. Okay, next we have angina. So this is going to be the primary symptom that you see in cardiac patients. Okay, basically this is going to refer to chest pain, most specifically after exertion, when there is now a decreased oxygen supply to the myocardium. Okay, so we have three big types of angina. So you have stable or exertional angina, unstable angina, and variant angina. Okay, so for stable, this is going to be the most common type. Okay, so here you have that artery that is blocked or narrowed due to your atherosclerosis. So at rest, it still gets enough blood to the heart. Okay, so at rest, they're probably not going to have any symptoms. But when their physical demands increase, when they're exercising, when they're doing some type of physical exertion, well, now there's not enough blood that's able to get through to the heart, and they're going to start exhibiting this symptom. Okay, so they're going to start having chest pain or difficulty breathing, but it's only while they're doing that physical exertion. Once they stop, they rest, they stop whatever they're doing, then everything returns to normal and their symptoms will decrease. Okay, so they'll return to their baseline. So that is your stable angina. Now there's also unstable angina. Okay, so this is when you still get these symptoms without an increase in physical exertion. Okay, so you're not getting enough blood to the heart. Okay, or if it does start while you're exerting energy in whatever way, shape, or form that is, and you cease that activity, the symptoms don't subside. Okay, so it's not going to be relieved with rest, it's not going to be relieved with medication. Okay, so here, that artery, you have a partial block or a complete block at this time, and this is now trending toward a medical emergency because they're likely going to be having a heart attack. Okay. Now the third type is variant angina. So this is going to be the rarest of the three, less commonly seen, and this is going to be caused by a spasm in the coronary artery. Okay. So the artery narrows, you still have a slowed or stopped blood flow to the heart, but it is due to a spasm. terms of the actual symptoms present with this, so like we said, chest pain, that's gonna be the big one, okay? Left-sided chest pain specifically. And then again, it could follow that same referral pattern. So going up into the jaw, going down into the left arm. Okay, they're likely going to, again, use some of those same terms that we mentioned earlier, like squeezing, crushing, a lot of pressure on the chest. It could go, again, up into the upper back, upper left shoulder. They could also have shortness of breath, sweating, dizziness, nausea. And again, this is likely going to increase with greater exertion. In terms of treatment, again, you immediately want to stop all physical activity. Okay, especially if you're seeing this in clinic, sit down, let them rest, just stop whatever you're doing. If it continues, if they have nitroglycerin tablets, you want to put that under their tongue. That is going to act as a vasodilator for these conditions, so it can be very helpful. After you take one, you wait 5 minutes. If they continue to have symptoms, you would go up to 3 tablets 5 minutes apart. If they still have symptoms after 3 tablets, you need to get them to the hospital or call an ambulance immediately because they're having a heart attack. Okay, did you have a question?
Just, is there anything that a panic attack, people have similar symptoms, or that this has that a panic attack doesn't have?
They can present very similarly. So one is important to know their medical history. And then if they have the nitroglycerin tablets, that's going to be important. Also, like pulling them out of the environment, getting them into a, darker space, somewhere quiet, where they're a little bit more isolated, cut off from everybody. You can talk them through like breathing, like trying to control their breathing to see if that will calm them down as well. But if there's ever any question, still just want to call 911 regardless. Okay. All right. So with this can obviously progress to myocardial infarction. Okay, myocardial infarction is going to be your heart attack. So basically, some part of the heart muscle has died due to lack of blood flow to that area of the heart. So this is going to be caused by occlusion of that coronary artery. Okay, could be different reasons though. It could be plaques, like we've already talked about. It could be due to a blood clot, or it could be due to spasm of the myocardium. Okay, so in terms of most common location for a heart attack, this is going to be the left ventricle. The left ventricle has to work harder than any other region of the heart, so it is most often affected. Okay. In terms of your signs and symptoms, this is going to be everything that we just talked about. Okay. So again, a lot of chest pressure, crushing sensation, referral down the left arm or up into the jaw. For treatment, you want to administer oxygen and then morphine to control pain. They're often given aspirin to reduce additional ischemia. Vasodilation is going to be really important. So once they're with emergency medical services, doing something like a nitroglycerin drip is going to help to control that vasodilation. And then heart muscle will fully die irreversibly within 6 hours. So if they're going to do surgery, it typically has to occur within that 6-hour window. So whether they do an angioplasty or a coronary artery bypass, that's typically going to be indicated within the first 6 hours. Okay, moving on to arrhythmias. So this is going to be any deviation from normal heartbeat, okay, or your normal sinus rhythm. This is basically irregular heartbeats. This is going to interfere with the heart's conduction system, and at some point, I think you guys will learn how to actually draw out a normal sinus rhythm. So let me check to make sure that's in the curriculum in a different class, and if not, we'll revisit this next week to make sure you guys know what that looks like. Okay. In terms of your symptoms, depending on what's going on, they're likely going to feel palpitations, They could have tachycardia or bradycardia. There could be skipped heartbeats. And this could also lead to syncope or fatigue as well. Okay? The treatment for this will depend on the underlying issues, the underlying causes. A lot of this can occur secondary to medications that somebody's taking. So if that's the case, looking for alternatives or stopping that medication if it is harmful to the individual. Anticoagulants are very important here. That will help to prevent any thromboembolisms, so blood clots being thrown. They might have to shock the heart back into rhythm. And then if that does not stabilize, of course, arrhythmias can be fatal. Okay, next we have congestive heart failure. Okay, so here this is basically going to be the heart's inability to pump enough blood to meet the demands of the body. Okay, so this is something that typically develops gradually and very silently, and a lot of people don't even know that they have this issue until it's too late. Okay, so one thing that's really important for you guys to be on the lookout for, always, with every single person, you always want to look at their ankles. Okay, a lot of times when somebody has congestive heart failure, they're going to have bilateral pitting edema in their ankles. Okay, and when you guys see your patients so much, oftentimes you can be the first one to catch something like this because they don't know that that's abnormal. Okay, so just every person, just something to get in the habit of doing. Always take a look at their ankles, and you can feel them. You can look for that pitting edema, and if you see it, then that can lead you to ask further questions about their medical history, if they have any known heart disease, and if not, then recommend that they go see their primary care physician just for a general checkup, make sure everything works okay. All right, that's a little bit of a tangent, but this is, when that is present, that is a very clear sign that something is going on cardiovascular. Okay, so this could be isolated to one side of the heart, or it could involve the entire heart. But most commonly, you see it on one side or the other. So you might have somebody with right-sided heart failure or left-sided heart failure. Okay? With right-sided heart failure, you're typically going to see an enlarged spleen and an enlarged liver. Okay? The peripheral edema here will be much more prominent. And that is going to involve underlying causes like an infarction specifically of the right ventricle, or more pulmonary issues, so pulmonary valve stenosis, something more involved like that. Versus your left-sided heart failure, here you're getting more increased pulmonary congestion and more pronounced respiratory problems. Okay, left-sided heart failure is going to be due more because aortic valve stenosis versus pulmonary. Okay, they're going to have more hypertension, hyperthyroidism, or infarction of the left ventricle. Okay, next slide also has a little bit of a comparison image for left-sided versus right-sided heart failure. Okay, you do have different classifications for your types of heart failure. Okay, so this is in a table in your book, so make sure you have this memorized. Okay, so class 1, this is going to be very minimal. You don't have any limitations here. Physical activity will not result in excessive fatigue, dyspnea, palpitations, or angina. Okay, so very, very minimal changes here. Class 2 heart failure is going to be mild, so they're going to be a little bit more limited in their physical activity, but they will still be okay when they're resting. So comfortable when resting, no issues there. But just regular types of physical activity is going to increase the amount of fatigue they have. They might have some chest pain, palpitations, or shortness of breath. Okay, class 3, this is going to be moderate. So this has very limited physical activity. They will still be more comfortable when resting, but very low level activity will cause all of these symptoms. okay? And then class 4 is classified as severe. So here, they cannot perform any physical activity without discomfort, okay? And at this point now, they're starting to develop cardiac symptoms just at rest as well. Okay, so those are your classifications for heart failure. Okay. All right, so on the next slide, we have a list of a bunch of different things that can result in congestive heart failure. So it is important to know what is happening, underlying reasons for this occurrence as well. Okay. In terms of your diagnosis, like we mentioned earlier, ECG, catheterization, lab tests, all of those are going to be important in order to diagnose these conditions. And then the goal of treatment is just to reduce the workload on the heart in whatever way is possible at that point. Okay? So it could be medication, could be surgical intervention, everything we've already talked about. Okay? Now all of this can lead to cardiac arrest. So cardiac arrest, this is going to be described specifically as the sudden, unexpected cessation of cardiac activity. Okay? So this is obviously an emergency. This is a life-threatening situation. The patient is unresponsive. They have no palpable pulse and no respiratory effort. Okay, so here, 911 needs to be called immediately, and you need to start CPR. Okay, so this, of course, can be caused. It can be caused by arrhythmias. It can be caused by respiratory arrest, by myocardial infarction, severe trauma, all different types of things. Okay. Ultimately, it is going to result from anoxia, which is basically interruption of the electrical stimuli to the heart. Okay. On the ECG, if this was to be taken during cardiac arrest, this is when somebody has a flat line. Okay, so there is no cardiac output at all. In terms of treatment, again, CPR has to be immediately initiated. Okay. It has to be initiated within 4 to 6 minutes. Otherwise, brain cells are going to die after 4 to 6 minutes. Okay? After 10 minutes, there is complete brain death with no chance of reversal of the condition. Okay? Defibrillation is going to be important here, used as indicated. And then, of course, there are also certain medications that are used in order to treat cardiac arrest. So that's where they're going to use something like epinephrine, for example, just to try to stimulate cardiac activity. Okay. All right, next we have carditis. So this is going to be an inflammation of the heart tissue. This could be due to infection or to immune system problems. Okay, there are 3 different types of carditis. So one is pericarditis. This is an inflammation of the pericardium. So that is the actual sac that encloses and protects the heart. 2 is myocarditis. So this is going to be inflammation of the actual muscular walls of the heart. And then 3 is endocarditis. That is inflammation of the lining and the valves of the heart. Okay, so make sure you know the difference between those 3 types. In terms of symptoms, they're all going to present very similarly. Okay, so here, palpitations, fatigue, dyspnea, fever, arrhythmia, chest tenderness. For endocarditis, this is usually going to occur due to an infection somewhere else in the body. Okay, so that type will have extra symptoms that are associated with that infection. So things that you would usually see in an infection: fever, chills, night sweats, etc. Okay? History typically will show some type of upper respiratory infection. That's involved. In terms of treatment, treatment is going to be aimed at whatever is going on an underlying condition in order that is actually causing the carditis. Okay? So managing any type of systemic disease, trying to reduce that inflammation and manage the symptoms. All right, next we have valvular heart disease. How is your guys' cardiac anatomy? Do you remember those things or no?
A little bit.
You know the heart has valves, right?
Yes.
All right, we'll start there, that's good. All right, so valvular heart disease. So here, those valves can also become dysfunctional, okay? So that can be acquired or it could be congenital. And it could involve any of the 4 heart valves. Okay, so we have valvular insufficiency. So basically in valvular insufficiency, the valves are not able to close completely. Okay? And there is also valvular stenosis, which is more a hardening of the valves. Okay? More often or more commonly, the mitral valve will be the ones that are involved as compared to aortic, but it can involve any of them. Okay? So mitral insufficiency, so we're gonna break these up into your 2 different types. So starting first with mitral valves. So mitral insufficiency, so here, the part that actually opens and closes becomes insufficient. So the actual mitral leaflets. Because of that insufficiency, you're gonna end up getting a lot of backflow of the blood. Okay? So it's going from the left ventricle back into the left atrium. Okay? So that is going to most affect the phase of the heartbeat when there's an actual contraction of the heart. Okay? Because of that backflow, so because you have that excess blood going from the ventricle back into the atrium, well now the atrium has to enlarge in order to accommodate this extra blood. Okay? That will then cause the ventricle to also dilate, because now the ventricle is getting more blood being pushed through from the atrium. Okay? So you're getting a ventricular hypertrophy, an increased end diastolic pressure, and that is going to result in increased pulmonary artery pressure. Okay? So while all that's happening, that is now eventually going to lead to heart failure of both the left and the right sides. Okay? So that's your mitral insufficiency. We also have the mitral stenosis. Okay, so here you have more a narrowing of the valves because you get that hardening of the valves. Okay? So this is going to obstruct the blood flow that's going from the left atrium to the left ventricle. Okay? So here you're going to have more exertional dyspnea. A cough will likely be involved where you don't typically get that as much with mitral insufficiency. They could cough up blood, and there could also be cyanosis. Okay? Versus your mitral insufficiency, that's going to be more just dyspnea, fatigue, or heart murmurs. Okay, for your aortic valves now. So aortic insufficiency and aortic stenosis. For aortic insufficiency, there's going to again be that same concept with your blood backflow that's going into the left ventricle during diastole. Okay, so that is going to cause more of an apical pulsation, a bounding type pulse, and you'll hear a diastolic murmur. Okay, for your aortic stenosis, here that left ventricular pressure is going to increase, trying to overcome the resistance from that narrowed opening. Okay, so that is going to increase the amount of workload on that ventricle and increase the demand for oxygen. Okay, so here you're going to have a diminished cardiac output. You have less coronary artery perfusion. It's going to end up with ischemia of the left ventricle and eventually left-sided heart failure. Okay. So in terms of symptoms for this population, again, they're typically going to have chest pain, syncope with exertion typically, and labored breathing with exertion. Okay, your next slide here for valvular heart disease is just a giant list of different types of ways to diagnose these conditions as well as different treatments. So of course, that's going to differ slightly depending on what is actually involved, what structure is involved, what the underlying issue is, all different types of factors there. Lastly, for this portion, we have rheumatic heart disease. Okay, so this basically is damage to the heart due to rheumatic fever. Okay, so that is going to be more a systemic autoimmune disease that's inflammatory in nature. It's going to involve a lot of the joints as well as the cardiac tissue. Right, this is something typically that begins in childhood, typically caused by strep throat, and then that turns into rheumatic fever. So here, a lot of different symptoms, as you can see on this slide, but a lot of joint pain, edema, decreased range of motion. In terms of the actual heart, they will have endocarditis. Oftentimes, there's going to be valve damage. It could lead to congestive heart failure, shortness of breath, elevated heart rate, a non-productive cough typically, and then cardiac murmurs as well. Okay. Again, important thing to know here is that this often is going to occur after a strep throat infection. Okay. All right, for the actual lab test here, when this occurs, the individual typically will show elevated white blood cell count and elevated erythrocyte sedimentation rate while it is actively occurring, so while they have that active infection. Okay. Typically, penicillin is used to treat the infection initially, and then otherwise it's just trying to prevent these things from occurring. Okay, before we get into blood vessels, let's do at least a little bit of an activity just to help try to wake you guys up a little bit. So either grab some whiteboards or you can write it on your sheets of paper, however you want to do it. But just as a review, I want you to try to draw out the heart, label the atriums, the ventricles, and try to trace the general blood flow through the heart. Okay? If you can't do it, that's fine. Use some resources. Use your book. Hang on. Before you move, just want to finish over. At the beginning section for this chapter, there is a brief cardiac review, just cardiac anatomy. So as you guys are studying, I want you to use that. Okay, make sure you read that section. And again, in anatomy, we will do a cardiac section in anatomy as well to help reinforce it. But let's just refresh on that. Again, just try to trace the general blood flow through the heart, and then take a bathroom break if you need to during that, and then we'll move on to blood vessels. Again, use that chapter in the pathology book just to refresh on some of that information as you guys are learning this lecture. Okay, so next we're going to go on to the actual blood vessel pathologies. Okay, starting first with hypertension. So here we have primary hypertension. This is going to just be basically abnormally high blood pressure in your arterial system. Okay. Again, this is something that typically will come on silently until it's too late. You already have that damage that's occurred. In terms of your signs and symptoms, it's common again to have some syncope with this, lightheadedness, headaches. Also, nosebleeds are associated with high blood pressure as well. For your risk factors here, age is going to be a factor, and stress. Stress is very highly correlated with hypertension, as well as personality. So more high-strung type A type personalities are more likely to develop hypertension as well. Okay, and then of course all of those modifiable lifestyle factors that you guys are aware of at this point. So obesity, high sodium intake, excessive alcohol consumption, low physical activity, etc. All of those things can lead to hypertension as well. All right, what is a normal blood pressure value? 120 over 80. Okay, so you have in your book, there's a table of your classifications for blood pressure values. You need to know these. Okay, so normal is going to be less than 120 over less than 80. Pre-hypertension is 121 to 139 over 81 to 89. Stage 1 hypertension is 140 to 159 over 90 to 99. And then stage 2 hypertension is greater than or equal to 160 over greater than or equal to 100. Okay, so again, make sure that is committed to memory. Okay, in terms of treatment, okay, you can treat this with medication as well as your lifestyle changes. Okay, for cardiac rehab, so you have these different phases for cardiac rehab for individuals with hypertension as well. This is similar to what we discussed earlier, but you do have one more phase here. So phase 1 is going to be your inpatient setting. So again, very low level here, high monitoring of the vital signs. Phase 2, outpatient setting. So here, again, similar, but now we're starting to increase the intensity, really focusing on independent function, increasing endurance. And then phase 3, you're still an outpatient, but this is now higher level physical activity. And then 4 is going to be discharged, typically to home, or, still higher level outpatient with more an emphasis on the aerobic activity. So more so thinking long-term plan here, independent management of themselves. Okay, we also have malignant hypertension. This is going to be a much more severe and life-threatening form of hypertension. So here you have a very severe and sudden onset of these symptoms. Okay, so same type symptoms, very severe headache, you could have blurred vision, shortness of breath, very high blood pressure. So over 200 over 120 is what indicates this type of hypertension. Okay, so you need very aggressive intervention at this point. So IV vasodilators, constant blood pressure monitoring, and then medication as well. Okay, orthostatic hypotension, this is going to be a postural hypertension. So here you get a decrease in blood pressure. So it is qualified with systolic pressure decrease of 20 or a decrease of 10 in both systolic and diastolic. Okay, so here there is also a pulse increase of 15 beats per minute or more going from sitting to standing. Okay, so this is what happens when you have a postural change. That postural change is what brings on the change in the blood pressure and the pulse. Okay, so this is something that you will very commonly see, especially in hospital settings and inpatient settings where someone might be spending a lot of their time in bed and you're coming in for physical therapy, you're trying to get them up out of bed and they haven't sat up in a while. Okay, they're not getting that blood flow pumping up as normally from the lower extremities. So in order to kind of counteract that for you guys, when you're working with those patients, trying to do some type of activity in the bed to get the blood moving before you get them up. So even something as simple as ankle pumps. So let's do, 3 rounds of 30 ankle pumps before you come to sitting. Do some activities in sitting, let them adapt to that position before you bring them up into standing. But oftentimes, you move too quick, you go from laying down to standing up very rapidly, they're gonna get dizzy and they might pass out. Okay, so just trying to make sure you give them time to accommodate to those positions, regulate the blood pressure a little bit more before you bring them all the way up. Okay, and then same thing, like you see it a lot of times going from sitting to standing, they might be fine, but then you start moving too quickly. So they come from sit to stand, okay, let's get to the bathroom. Same thing, like make sure you give them time to accommodate to a standing position before you start walking. Okay. In terms of your signs and symptoms, like I said, passing out is going to be very common here. Blurry, loss of vision, and dizziness as well. Shock. Again, this is going to result from extremely low blood pressure. There are different types of shock. Okay, so you have anaphylactic, cardiogenic, hypovolemic, neurogenic, and septic shocks. Okay, so a lot of different types. And you can see a little bit of a description on the slide for each of those. But overall, the important thing is this can lead to organ failure very rapidly, okay? So symptoms of shock in general, the patient is going to present with pale, cold, clammy skin, oftentimes cyanosis, tachycardia, altered mental status. They could be unconscious, or have reduced or no urine output. In order to qualify as shock, blood pressure has to be less than 90/50. Okay? This is something that requires immediate action. Okay? So for you guys, if you see a patient, if this is occurring for whatever reason, you need to lay them supine and elevate the legs. Okay, the legs need to be elevated above the level of the heart to help return the blood flow to the heart. Okay, you want to try to keep them as warm as possible, keep them in a calm, quiet environment as well. Okay, next we have aneurysms. Okay, so here this is going to be the weakening and local dilation of the wall of an artery. Okay, again, there are several different types of aneurysms, and these can occur in different locations. So there are saccular, fusiform, and dissecting aneurysms. Those are the three big categories. For the saccular, and that image is good to show the different types as well. But for saccular, so here this is going to result in a little bulge on one part of the artery, or on one side of the wall of the artery. For fusiform, this is going to be more a spindle-shaped aneurysm. Okay, so you're going to get more a circumferential type bulge. Okay, versus dissecting. So here, there's actually going to be a separation of the arterial wall. Okay, these can occur either insidiously or very acutely. Okay. The symptoms are going to be different depending on the actual location of the aneurysm, as well as the severity of the aneurysm. Okay, the most common type that you see is called a AAA, which is an abdominal aortic aneurysm. Okay, so here again, that is a very urgent medical emergency. If it's not caught, it's very likely that a person will die if that's something that happens. Okay. In terms of just like a general aneurysm, a lot of times these are going to occur secondary to atherosclerosis. So everything that we were talking about at the beginning, you have that buildup of plaque that weakens the vessel wall. Okay, it could also occur from trauma, from infections, from inflammation, all different types of things. Okay, for the abdominal type, since we said that's the most common, you can palpate. You'll palpate a pulse if this is something that's present. Okay, typically you go straight lateral from the belly button. Okay, and you can measure it by your fingers. So if you can feel a pulse lateral to the belly button, and then how many fingers can you feel it with? Okay, so that's how you would measure it. That's how you would document it or relay that information to a physician. Okay, so basically you would be noticing an aortic mass at that point. If you used a stethoscope, you would hear a bruit in that area if you were to put the stethoscope over top of that mass as well. Let's see, cerebral aneurysms, those are also very common. That's occurring in the brain, but typically those are not found until after they've already ruptured. Okay? So usually those have pretty severe consequences. The goal is to identify these things and repair them prior to rupture, okay, or leakage. So these are all things that would require surgical intervention. And typically they would use a graft or something to help support the arterial wall. All right, next we have vasculitis. So this is going to be more a group of disorders where the blood vessels are destroyed due to inflammation. Okay, so in terms of classification, they are going to be classified by the size of the vessel that's involved. These could be, again, this could occur acutely or more chronically. They could have more neurologic manifestations, but overall, the site is going to depend on the immunity complex in the actual blood vessel. Okay, Your symptoms are going to be based on the organ that's involved. So these could present in very different ways, okay? In terms of treatment, it's going to have to address the inflammation, so suppressing the immune system in some way. Typically, you'll see prednisone used with these conditions, and then any type of antimicrobial if there is an infection present. Phlebitis is going to be inflammation of a vein, okay? These most commonly occur in the extremities, so most often lower extremities as compared to upper, but again, it could occur anywhere. Oftentimes, the veins will become swollen, tender, and it will increase in severity over time. Okay. Causes here are, this is typically due to a slower blood flow through the vein. It could also be due to obesity, blood disorders, or any type of previous injury or surgery. In terms of treatment, this is going to be more dependent on analgesics and just symptom management in general. Okay. If this is something that is present, you do not want to massage these veins. Okay, you'll see people do that just to try to help manage their symptoms, but this can also result in an embolus. So formation of the clot in that area that is then removed or moved to a distal site because of massaging that area. So if somebody presents with this, you want to make sure that you know to leave it alone and that you educate your patients to leave it alone as well. Okay. Similarly, we have thrombophlebitis. So this again is going to be inflammation of a vein and then the actual formation of the thrombus on the vessel wall. Okay, so again, same thing here. This is typically something that occurs in the lower legs. They're going to have pain, swelling around that area. It's going to impede the blood flow, and it's going to have increased inflammation in the area that is actually involved. Okay. This is more emergent, so it does need more immediate intervention because you are fearful that that thrombus will, basically like throw a clot to the lung, okay, or somewhere else. So making sure that that blood clot is taken care of so it doesn't get worse. Okay, so next slide we have is thrombosis. So basically everything that I just said here. So the blood clot from the limb has gotten lodged in the blood vessel and now it is blocking the blood vessel. Okay, so you have two big types here. You have venous and arterial thrombosis. Typically these will present unilaterally. Okay, so it starts typically in the lower extremity, usually in the calf most commonly, and also in the inner thigh. So here, there could be swelling in that region. They could have very severe pain. Oftentimes, they will complain of very severe calf pain, okay? But I've seen both extremes. Could be that, or they're completely symptom-free. They have no idea that anything is wrong until it's thrown a clot to the lung, okay? So something that you always want to be cautious of and always look for in your patients, okay? So again, typically unilateral, very severe lower extremity pain. It could result in unilateral numbness, weakness, more the severe pain. It could result in mental change as well, but typically it's just pain, okay? Like I said, we have two different types. There's venous thrombosis and there's arterial. Arterial is more likely going to occur following a rupture of plaques, okay, and then result in blood clotting. So of course that could lead to stroke or heart attack as well. In terms of treatment here, anticoagulants, so trying to thin the blood a little bit, making sure it doesn't clot, dilate the blood vessels, and then any additional medications to help dissolve blood clots as well. All right, pulmonary embolism. So all of those things that we just discussed can then lead to a pulmonary embolism. So here you have a blood clot that is now occurring within the pulmonary artery. Okay, so oftentimes that starts at a distal site, goes through the vessels, and gets lodged in the pulmonary artery. Okay, So then that part gets obstructed. So it could be due to different types of things. It could be due to air, to bone marrow, to fat, to the plaque, to blood clot, etc. So all of those different types of things could cause a pulmonary embolism. Like I mentioned earlier, this could be totally asymptomatic, or they could have very severe symptoms. So they can present in very different ways. But most likely, once it gets to this point, they're gonna have difficulty breathing, they're probably gonna have chest pain, high blood pressure or high heart rate, and very severe anxiety, because they can feel something's wrong at this point, okay? Again, your most common cause of pulmonary embolism is going to be a deep vein thrombosis. So again, blood clot that has started in the lower legs and traveled up to the pulmonary artery. So at this point, they're gonna need oxygen, vasopressors, clot eliminating, medications, etc. Okay? This is a very common cause of sudden death in individuals. Again, that is why it is so important that you are regularly checking for these things when you're working with your patients in clinic, because this happens very quickly. Okay? So most commonly, depending on, the type of environment that you guys work in, this most commonly occurs if you're in outpatient world, post-operatively. Okay, so somebody's had a surgery, they've been in bed, they're not doing their regular daily activities, blood is not pumping like normal. If you're in inpatient, if you're in hospital settings, it can happen just from being more bedridden. Okay, so if they're not up and they're not moving, blood is not pumping, it's very easy to get these DVTs in the lower limbs. Okay, that's why if you go into hospital settings, you see those little like leg pump things that are plugged in and they just kind of squeeze the lower legs. That is helping to prevent these types of things from happening. Okay, so one of the very first exercises that you'll teach your patients, whether it's post-operative status or patients who are more hospitalized, more bedridden, is always ankle pumps. Okay, this is why, because that ankle pump is helping to facilitate blood flow through the lower limbs, so you're not getting these blood clots, so it's not resulting in pulmonary embolism. Does that make sense? Okay. Okay, next we have varicose veins. Okay, I'm sure this is something you guys are familiar with. Basically, you have really swollen, twisted, knotted veins in the lower legs. Okay. Again, this is something where this, occurs insidiously. It gets worse over time. A lot of times, these patients will feel just kind of generalized achiness in their lower legs, and they're probably going to have a lot of cramping in their legs as well. These veins will start to thicken over time, and they will get harder as the disease progresses. There's no specific type of cause that is known for this, but there is suspicion that the valves in these veins are either defective or completely absent, so they're not regulating the blood flow as expected. These are pretty easy to diagnose just because you can very easily see them in somebody. And in terms of treatment, a lot of it is going to be lower leg elevation. So again, having a patient lie supine, get the legs elevated up above the heart to help facilitate the return of the blood flow back to the heart. Wearing stockings is also helpful for this, so they get that little bit of compression that again will facilitate the return of the blood flow. As it progresses, it might be something that requires surgical intervention or support in order to help atrophy the actual existing affected veins.
Are they still doing stripping?
Mm-hmm.
My mom had it done when she was living overseas, but she told me that
Really?
they don't do it here.
Yeah, it's not something that you will very commonly see.
And how does that help? I mean, it gets rid of the painful veins.
Yeah, it basically is more like symptom modulation, and there's so many different vessels in the body that blood flow will end up taking alternative routes to get where it needs to go. Okay, DVT, we already touched a little bit about this, but again, this is very commonly something that you will see in the lower legs. And you have those clots that form in the lower legs and then get thrown to the pulmonary artery where you get the clot in the actual lung, okay? So we don't need to spend a ton of time here since we've already talked about it, but basically, oftentimes, you're gonna have one extreme or the other where they're completely asymptomatic until they have the blood clot in the lung, or they have that very severe calf cramping. And it can be very difficult to know, because a lot of times you'll have these occur after a lower extremity surgery. So you don't know if that calf cramping is just regular post-operative pain versus, oh, something is really wrong. So if you have a situation where you are unsure, it is always better to call their physician, get them sent for some imaging of that area, and be wrong rather than miss something like this. So always err on the side of caution when it comes to calf cramping, okay? In terms of risk factors, again, immobility, that's the most common thing that you're gonna see this with. So prolonged bed rest, immobility post-operatively, whatever it may be, that is when this is most commonly going to occur. Obesity, pregnancy, leg surgery, pelvic surgery, and varicose veins are also listed. In terms of treatment is just gonna be aimed at reducing the blood clots, okay? So they're likely gonna be put on blood thinners to help reduce the clot and other casts. And then, let's see, and anticoagulants. So other than that, we've kind of gone over everything on that slide, so just make sure you understand really the importance of this when it comes to clinic. Okay. Along with this, we also have what's called Wells criteria. Okay, so this is your technical evidence-based practice for assessing for DVTs. Okay, so you have all of these factors that are listed out on your slide. So active cancer, if they're bedridden for greater than 3 days, if they've had a major surgery within the last 4 weeks. Okay, this list is something that you guys need to commit to memory. Okay, so as you are looking at these different factors, these are the questions that you need to be asking yourself as you are working with the patient. Okay, do they meet the questions on this list? Okay, and this is how you can kind of clinically reason through if it is likely that somebody has a DVT versus, okay, they might just have some lower legs. All right, 2 more here. We have Raynaud's disease. Okay, this is a vasospastic condition. Typically, this occurs bilaterally. You most often see these symptoms in somebody's hands. You could also see it in the feet, but that is not quite as common. So here, they basically have a vasospasm of the very small peripheral arteries or arterioles. This is usually most evident when somebody is cold or stressed. Okay, and basically they just get a white discoloration, usually just of the fingertips. And you can see that in the picture on the slide. Okay, the cause of this is technically unknown. It is suspected that it is aggravated or worsened by use of tobacco products or cigarettes. Okay. With that discoloration, they could also have some numbness in their fingers as well. For diagnosis, there is a test for an antibody that they can look at to see if they have this, because it is technically an autoimmune disease. Using a Doppler ultrasound for reduced blood flow. That is also, just to go back to our last couple slides, the Doppler ultrasound is how they would assess for DVT as well. So if you suspect somebody has a DVT, you call their physician, and the physician is going to refer them likely to an emergency room to get a Doppler ultrasound to look for the presence of blood clots. Back to Raynaud's though, in terms of treatment, you would try to warm the area and then encourage, smoking cessation if able, avoiding any of those stressors or excess exposure to cold temperatures. All right, last one here is Buerger's disease. So this is going to be an inflammation of the peripheral arteries and the veins of the extremity, okay? You're also gonna have the formation of clots here. Okay. In terms of signs and symptoms, this is going to be very intense pain in the area that is involved, okay? Again, typically, I know I think, this is a picture of the upper extremities here, but typically, most commonly, this is going to involve the lower extremities or the feet, okay? This is going to result in symptoms, again, where there is coldness, cyanosis, or numbness of the extremity when exposed to lower temperatures, okay? After that initially subsides, that cold feeling, it's then gonna feel very hot to the person. So it'll be warm, it'll feel tingling, it'll feel hot, it'll be red, and then this is typically aggravated by exercise and something that is alleviated with rest, okay? So a lot of this goes again back to blood flow. If that blood flow is not eventually restored, then it's going to result in atrophy of the area, ulcers, and gangrene, okay? This again is something related to smoking, okay? So the underlying cause is long-term use of tobacco products. So therefore, treatment, again, is a lot of education on smoking cessation, and then trying to restore circulation to the involved area, okay? If it is something that has turned into gangrene, then likely it will have to be amputated, okay? Other than that, other than the smoking cessation, there is not a known cure for this. All right, so that is it for cardiovascular disorders. So let's take, same thing, let's take like a 10-minute break or so, and then we'll move on to the next chapter. We're gonna move on to blood disorders. Hopefully this first portion is a little bit of a review from stuff that we've already talked about with the different types of blood cells and everything, and then we'll get into the different types of disorders. So let's start first with your blood components. So obviously we know blood is really important to the body, right? It helps to supply nutrients, oxygen, glucose, electrolytes, hormones, all of those things. And also it helps to remove different waste from the body, okay? It has a really big role in controlling temperature. So it helps to distribute heat through the peripheral tissues. And then it also transports specialized cell in order to help defend against infection. Okay, so when we talk about the breakdown of blood, we know that we have red blood cells and we have white blood cells. So what are the primary actions of those different types of cells? Perfect. So red blood cells are going to carry oxygen. White blood cell is going to fight against pathogens. Okay, so then we also have platelets. Okay, these are also called thrombocytes. Make sure you know the different types of names for all of these things as well. These are really important when it comes to blood clotting, okay? So they basically can adhere to any type of damaged tissue, they can adhere to themselves, and it helps to form a small plug or a seal in a seal of any break in blood vessel, okay? So that ability to adhere is what is reduced with blood thinning medications, so things like aspirin, okay? It reduces a platelet's ability to adhere. That's how it thins the blood, okay? We also have hematocrit, so this is the portion of cells in the blood, okay? So this is mostly your erythrocytes, which are your red blood cells, okay? So that is going to influence how viscous blood is, so how thick or how sticky it is. Okay, next we have blood plasma. This is the fluid extracellular matrix. Okay, so basically the liquid form of blood. So within this is where your red blood cells, your white blood cells, and your platelets, this is where it all floats in this blood plasma. So this is going to make up about 55% of the actual blood volume. Okay. We also have red bone marrow. Okay, this is where your blood cells are actually going to originate. Okay, so this is your only site of blood cell production. Okay, so next slide we have erythrocytes. So these are your red blood cells. Okay, your kidneys secrete a hormone that is called erythropoietin. Okay, that is what stimulates the actual production of the erythrocyte in the red bone marrow. Okay, that occurs in response to hypoxia. Okay, hypoxia is going to be insufficient oxygen. Okay, so this is something that could occur during anemia, during hemorrhage, if there's any type of disrupted blood flow to the kidneys at all. Okay, in general, red blood cells are going to live for about 120 days. Okay, as they get older, they become more rigid and they become more fragile. Okay, they are going to undergo phagocytosis in the spleen or in the liver. Okay, then we have leukocytes, so these are going to be your white blood cells. Okay, at this point we should know these are going to be a very important part of your body's defense system, specifically against infection. Okay, we have 5 different types of leukocytes. Okay, they are classified into 2 different groups. So we have granulocytes and agranulocytes. The granulocytes are going to have a large granule in their cytoplasm. Okay, and these are going to include the neutrophils, basophils, and eosinophils. Okay, versus your agranulocytes, these do not have granules. So these are going to include your lymphocytes and your monocytes. Okay, so the next slide has all 5 of your leukocyte types. Okay, so again, neutrophils, basophils, eosinophils, lymphocytes, and monocytes. These are your 5 different white blood cells. Okay, so neutrophils, this is going to be the most common, most prominent type of white blood cell. This is going to compose about 50 to 75% of all of your white blood cells. Okay, these only survive for 4 days. Okay, so not very long. And of course, they are going to increase in number in response to bacterial infections. Okay, basophils are going to drive your body's response to allergens. Okay, so these are involved in the release of histamine and heparin. Eosinophils, again, this is going to be involved in that histamine effect where it opposes the effects of histamine, and these are increased also in response to allergic reaction as well as parasitic infections. Lymphocytes are the other major type of white blood cell. Okay, so these are going to make up 25 to 45% of your white blood cells. Okay, so these will help to make antibodies and to kill tumor cells. And then monocytes are going to enter tissue in order to become macrophages, and they will act as phagocytes when tissue damage occurs. Okay, in terms of your diagnostic test here, the most important thing regarding your white blood cells is going to be a CBC, so complete blood count. Okay, it gives a ton of information on what is going on in the blood. Okay, so it's going to show the total red blood cells, white blood cells, platelets, and then the differential for the white blood cell. Okay, hemoglobin, hematocrit, all of that will be a part of your CBC as well. So, in terms of diagnosing anything, specifically for your white blood cells here, we have leukocytosis, which is going to be an increase in your white blood cell count. Okay, that typically is going to signal some type of infection or inflammation occurring in the body. Okay, that number has to be altered in order for the breakdown of the differential white blood cell count to be important. Okay, so when you get your breakdown, like if you guys look at your regular blood work, you'll have a breakdown of your neutrophils, basophils, eosinophils, but if there's nothing wrong with your regular white blood cell count, those values are irrelevant. That doesn't give you any important information. Okay, So there has to be an abnormality in the white blood cell count for that breakdown to then become important. Does that make sense? Let's see. On the other side, we also have leukopenia. So that's going to be just a general decrease in leukocytes. That's typically present with viral infections. And it can also be caused by radiation and chemotherapy as well. Okay? In your CBC, you'll also get a value for hematocrit. So that is going to show the percentage of red blood cells in the blood volume. Okay? So typically, low red blood cell count will indicate anemia. We're going to go over a lot of different types of anemia today. So that's the value you're looking at there. Okay, so we're going to move on first to specific red blood cell disorders. Okay, so like I said, a lot of different types of anemia here. Okay, so if you just hear the term anemia, that is in reference to a group of different signs and symptoms. Okay, so just in general, when anemia is present, there's going to be a decrease in hemoglobin, which results in reduced oxygen transport in the blood. Okay, this is something that can happen acutely or chronically. If this occurs acutely, okay, typically you have something that's occurred very rapidly, whether that's trauma, internal bleeding, whatever it is, you have to be most concerned for hypovolemia and shock in those situations. Okay? With more chronic types of anemia, those things are not as much of a concern. Okay? With chronic anemia, you're not having a change in the actual blood volume, typically just the contents of it. So usually you have an iron deficiency anemia, where there's low serum ferritin levels. Again, you're getting that reduced oxygen transport, but the actual blood volume has not changed. Okay? All right, so just in general, when somebody has anemia, for signs and symptoms, they're gonna feel more fatigued, they're gonna feel weak, they might have some dizziness, some pallor, shortness of breath, and an elevated heart rate. Okay? They may also have what is called pica. Does anybody know what pica is?
Craving things.
Craving what?
Craving things that aren't food or.
Dirt. So most common in anemia, you're going to see people craving dirt and ice.
Or chalk.
And what?
Chalk. Chalk's a big place I see craving.
Chalk. So dirt and ice are the two most common. Okay? So if you have somebody come in and say, I really want to eat some dirt, that should be a red flag. Hey, they probably have anemia. Okay? This can also, if very severe, can lead to angina, okay? Or even congestive heart failure, okay? In terms of causes for anemia, okay, you have nutritional deficiencies, impaired bone marrow function, excessive blood loss, or excessive destruction of red blood cells, okay? For your more chronic types, it is most common that it's a combination of overexertion physically with a combination of the nutritional deficiencies, okay? All right, so we're gonna go through a couple different types of anemia, okay? The first being the actual iron deficiency anemia. So here you have increased demands on the stored iron in the body, which is more than what the body can actually supply. Okay, so again, you have low serum ferritin levels. You are not able to supply enough oxygen transport in the blood. Okay, so again, the person's probably not getting enough iron in their diet. They could have some type of chronic blood loss. For women, it could be a result of excessive menstrual flow. Okay, so again, some type of combination of the nutritional deficiencies with blood loss. Okay, it could also be an absorption issue. Okay, they might be getting plenty of iron in their diet, but then the body's not actually absorbing that iron. Okay, so sometimes when that happens, the doctor will put them on some type of iron supplement but that still is not solving the problem because it's an absorption issue. Their body's not actually absorbing the iron. Okay, so in terms of symptoms, it's still gonna be the same symptoms that we already talked about. Okay, these are all gonna present very similarly. Okay, in addition, they're likely gonna have cold intolerance. Their nails are gonna change, so the nails typically become very rigid and they may turn concave. Okay, there may be delayed wound healing, menstrual irregularities. Again, fainting, syncope could become a part of this when you're not getting enough oxygen and blood flow. For the diagnosis, again, this is gonna go back to the CBC, the complete blood count. So looking at the iron binding capacity in the blood can be an additional test to the CBC as well. Okay, but mostly you're gonna look at that, it's gonna show low hemoglobin, low hematocrit, low serum ferritin, you're gonna see all of that stuff just from the regular blood work. Okay, there's also folate deficiency anemia. Okay, so this is a megoblastic anemia due to insufficient folic acid. So here, the red blood cells are going to become larger in size, but there's going to be a lower number of red blood cells total. You most commonly see this in infants, okay? You'll also see it maybe in adolescents when they're having growth spurts and in pregnant or lactating women, okay? But typically, the most common cause of this is going to be a folic acid deficiency and dietary or lack of nutrition in their diet. For symptoms, again, you're still gonna have a lot of those same symptoms from your general anemia. In addition, you may have more mental changes here, so more forgetfulness, difficulty concentrating. They may have more weight loss, more GI issues, so nausea, vomiting, diarrhea, those types of changes as well. In terms of diagnosis, again, this is gonna go back to your blood test, okay? There's going to be evidence of a deficiency in folic acid. Okay, so vitamin B will also show as deficient in these, in the blood work of these individuals. In terms of treatment, just adding a daily folic acid supplement will be sufficient to bring those levels back to normal. Okay, this is also very important for women who are pregnant. Folic acid is very important in order to make sure the baby grows as appropriate. So if you're of that age, if you're planning to have a baby, make sure you're taking those folic acid supplements during that process. All right, we also have pernicious anemia. This is also called Addison's anemia. This again is going to be progressive. It is megoblastic, macrocytic anemia. So again, you're getting those abnormally large red blood cells here, okay? This is going to be caused by a lack of intrinsic factor, which is really important for vitamin B12 absorption, okay? So here, the maturation of the red blood cells in the bone marrow has become disordered and is going to result in low hemoglobin levels, okay? So here, if you don't have enough vitamin B12, then that ultimately is going to restrict the growth of the red blood cells, okay? So you're gonna get those deformed red blood cells. They're going to have a lower oxygen carrying capacity, and that is going to result in anemia. Okay, so these individuals are either not getting enough B12 in their diet, or their body is not absorbing the B12. Oftentimes, if somebody has anemia, they don't necessarily know what kind it is, they'll automatically put them on both an iron and a vitamin B12 supplement, just to make sure all of this is regulated. Okay, same symptoms here though: fatigue, weakness, pallor, weight loss, etc. Okay, so in terms of diagnosis, there's going to be a B12 deficiency, so you can see that in the blood work. They could also look at the bone marrow to have a better idea of what's happening with those red blood cells. In terms of treatment, again, all of these things are likely going to be treated together. So iron supplement, folic acid, B12, increasing those daily supplements to help address any form of anemia. Okay? There is also B12 injections if necessary. Okay? But again, if this is something that goes untreated, then it's going to stress the cardiovascular system a lot, and it could result in more permanent neurologic damage. All right, next we have aplastic anemia. Okay, so here the bone marrow becomes hypocellular, and there is an increase in the fatty tissue. Okay, this does not have as much of a known origin, but it is likely related to some type of toxin. Okay, so you most commonly see these in relation to people getting radiation therapy or chemotherapy. This is typically something that has an insidious onset, usually, within weeks or months of exposure to one of those types of toxins. Okay, these individuals will present slightly different. They will have more of a waxy pallor of the skin. Their skin has actually changed in texture. They will still have the weakness, shortness of breath, fatigue, and they will have more of a tendency for excessive bleeding. For diagnosis, you're still going to do the regular CBC count here, but they will also likely need a bone marrow biopsy. In terms of treatment, there will have to be a removal of any of those bone marrow suppressing agents. Okay? Depending on their stem cell levels, it is more likely that they will need a blood transfusion. And then in younger patients, if it's something that's able to be tolerated, potentially a bone marrow transfusion as well. All right, we also have sickle cell anemia. Okay, so this is going to be more a genetic disorder. You still have abnormality of the hemoglobin molecules, but it is genetic. So here, the hemoglobin actually sickles, and there's a decreased amount of oxygen in the blood. So the cells will become more elongated in their shape, and ultimately they're going to be more fragile. They're going to be easily destroyed. This is a recessive inheritance. So basically the patient is homogeneous. So they have 2 sickle cell genes. Okay. Because of the shape of these red blood cells, they cannot flow easily when they get to the tiny capillary beds. Okay? So it is common that they will cause obstructions and kind of clump up together in those tiny capillary beds. So ultimately, you're going to restrict the continuation of the blood flow. Okay? In terms of signs, oftentimes this is going to occur, or signs are going to become more present when they get to higher altitudes. Okay, so when there is severe hypoxia at those high altitudes, or if they have some other condition such as pneumonia, that's going to be where it more commonly manifests. Okay, there is a blood test that can detect carriers for this gene. It can be checked prenatally, looking at a DNA analysis of the blood. In terms of treatment, there is not necessarily any type of treatment for this. It is just focusing on maintenance of any complications that may arise as a result of this condition, okay? Or just symptom management. They're having pain, meds, but other than that, there's no actual treatment. The biggest thing is just to try to avoid very high intensity exercise, especially at higher altitudes. Okay. How are you guys doing?
Little brain dead.
Little brain dead? Let's pause there, find a different partner in a different row, and then go through each of your types of anemias. Just one to get the terminology down, learn the different names, and then just pick out kind of a couple of the important points from each of them. Maybe take like 10 minutes or so to do this, and then we'll My
That's
bad.
okay.
So this is a hemolytic anemia that is also due to genetic defect, okay? So here, there is a reduced number of red blood cells, and reduced amount of hemoglobin that's able to be synthesized. So this has two different types. There's thalassemia alpha and thalassemia beta, okay? So normally, for a normal molecule of hemoglobin, there are 2 alpha and 2 beta chains, okay? So the different types dictate which portion of the hemoglobin is dysfunctional. So in thalassemia alpha, there's a reduction in the alpha chains, okay? In thalassemia beta, there's a reduction of the beta chains, okay? They also have a major and minor form, so thalassemia major is going to be much more severe versus thalassemia minor is a more mild form, okay? As a result of this occurring, there is going to be hyperactivity in the bone marrow because it's going to try to compensate for that anemia, okay? But in terms of actual presentation for symptoms, thalassemia minor is typically asymptomatic. Once it becomes major, it is also called Cooley's anemia. That's an alternative term that you'll hear. They're gonna have more severe symptoms, so anemia, everything, all the symptoms that go along with your generalized anemia, as well as jaundice, leg ulcers, gallstones, and then enlargement of the spleen. So those are all things that you may also see with this type of anemia. Okay. In terms of diagnosis, you can use X-ray to look at the chronic bone marrow hyperactivity. There's going to be a change to the actual structure of the bones where the skull and the long bones are more thin and the marrow space is wider. Your CBC, your blood test, that will show the change in red blood cells, the low hemoglobin. Typically, there's actually an excess amount of iron in this type of anemia. Okay. For treatment, the only type of treatment for this condition is going to be a blood transfusion. All right, next we have polycythemia. This is going to be an overproduction of red blood cells. So here, hematocrit levels are going to be greater than 50%. There are 2 different types. We have primary and secondary polycythemia. So primary is going to involve the bone marrow stem cells. Okay, it's going to be a proliferative disease of those bone marrow stem cells. So here, there's going to be an elevation in white blood cells and platelet counts, okay? They will also have the splenomegaly with an enlarged spleen and low serum erythropoietin levels. That does not have a known cause. For secondary polycythemia, there is going to be increased erythrocytes in response to prolonged hypoxia and increased erythropoietin secretion, okay? This type typically occurs as a result to hypoxia. In terms of symptoms, these patients are going to appear either reddened or cyanotic. Their face may be red. Again, they may have the splenomegaly present, and pruritus is often common with this population as well. What is pruritus? Itching, okay? Often they will also have blood pressure increases as well. In terms of test, they're likely going to show increased cell counts, hemoglobin values, and hematocrit. And then for treatment, they need some type of suppression treatment. So suppression of the bone marrow activity or removal of the blood. Now, for all of these types of anemia that we've talked about, transfusion is often a common treatment that is involved. So that could include either whole blood transfusion or just the red blood cells, okay? If there is a situation where there has been a massive trauma, massive amount of blood loss, that's when you're more likely to see a whole blood transfusion versus something more chronic, like a chronic type of anemia, an iron deficient anemia. That's when you're more likely to see just a transfusion of the red blood cells, okay? So this is typically going to be a step that is considered once hemoglobin is less than 7 or 8 grams per deciliter. Okay? Now, when it comes to transfusions, it's going to be very important to have good blood type compatibility. Okay? So that's what these charts are indicating on this image. So you have 4 major ABO blood groups, and they're differentiated by either the presence or the absence of the 2 red cell antigens, which are A and B. Okay? So patients who have neither A or B antigens are classified as having O type blood. Okay? That is the universal donor type. Okay? It will not cause an adverse reaction to whoever is receiving it. Okay? AB positive is going to be the universal recipient. Okay? They could receive transfusions from any type without any ill effect. Okay? Now, if the blood types are incompatible, you can have what is called transfusion incompatibility reactions. Okay? So that's when you have mismatch in types of the type of blood transfusion that has occurred. Okay? So they will likely, if this occurs, the patient will likely have an immediate reaction. Okay? That can be fatal. Something else to consider when it comes to transfusions is called the RH factor. Okay? So people who have an RH antigen are considered to be RH positive, and those without it are RH negative. Okay? This is basically just a protein that is found on the surface of the red blood cell. Okay? This can become specifically a big problem during pregnancy. Okay? So say an RH negative mother has an RH positive baby. Okay? At birth or with miscarriages, the placental membrane tears, and that is going to allow for a mixture of those bloods. So the fetal blood gets into the maternal bloodstream. Okay? And the mother works to form antibodies against the baby's RH factor. Okay? So if that occurs within 72 hours after birth, the mother has to be injected with the antibodies before her body can respond to it. Okay? So if an RH positive baby is born to an RH negative mother who has not received those antibodies, they are then at risk for brain damage and for death. Okay? So it's just something that has to be looked at and addressed as needed. Okay? But all of it goes back to making sure blood is compatible with each other. Okay? So if the blood is incompatible, there's going to be that antibody antigen reaction. It's going to result in the clumping of the red blood cells. If this occurs specifically in regard to the RH factor, symptoms will likely include chills, fever, tachycardia, very severe pain, and vomiting. Okay? In order to diagnose this, basically you could use blood or urine specimens in order to look for that compatibility or incompatibility. Okay? For treatment, this is basically monitoring the severity of the reaction. If it is more mild, then it could just be treated with an antihistamine. If it is more severe, it would be more like an anaphylaxis response as needed. All right, we're getting there, guys. So we have white blood cell disorders next. Again, hopefully some of this will be a good refresher from the beginning of this semester, since it's a little bit more dependent on white blood cells. So leukopenia, again, this is going to be low levels of leukocytes in general. So in terms of an actual value, it would be less than 4,000 per microliter. Okay, so that is when leukopenia is indicated. When that occurs, obviously the body's immune system reaction is going to be reduced as well. So you have a reduced response to bacterial infections. Neutropenia is going to be a specific form of leukopenia where you have a reduction in the neutrophils. Okay, so oftentimes, since that's your most prominent type of white blood cell, those terms are often used interchangeably. Okay? Your neutrophil count is going to be the most important indicator of infection. In terms of symptoms, there's likely going to be fatigue, weakness, potential for a sore throat, dysphagia, chills, and a weak and rapid pulse. For diagnosis, this is again gonna go back to your CBC, so you're gonna see that change in white blood cell count and a change in the differential for white blood cells. Further than that, if needed, you could also look at bone marrow or blood culture. In terms of treatment, this is gonna be antimicrobial therapy, trying to eliminate whatever that causative microorganism is. Neutrophilia and granulocytosis. So neutrophils, like we said, we know that this is the most abundant type of white blood cell. They are also going to be the first responders to reach an area of infection. So neutrophilia is where there is an increase in the number of white blood cells in the blood, okay, of the neutrophils in the blood. Granulocytosis is an excessive amount of granulocytes in the blood, okay? So both of these are going to occur early on in an infection and early in that inflammatory process, okay? So when you do the white blood cell count, when you look at the differential and you see these change in values, that's your indicator that there is an infection that is present in the body. Basophilia, this is going to be most important when it comes to chronic myeloid leukemia. Okay? So the granules of basophils contain heparin, histamine, platelet activating factor, and a lot of different proteins. So as these basophils release the histamine, there's going to be more of a local inflammatory response that is more an allergic type reaction. Eosinophilia, so similar here, you have an elevation of the eosinophils in the blood. And in terms of a specific value, it is going to be elevated greater than 500 per microliter. Again, this is most often related to allergic reactions. Lymphocytosis, so an increase in the number of lymphocytes in the blood. This is going to occur in the presence of acute viral infections, okay? Most specifically, the Epstein-Barr virus. Lymphocytopenia, this is something that can be acquired or congenital. It is going to be connected with abnormal lymphocyte production. So typically immune deficiencies will be present here and could also result from lymphocyte destruction due to different types of drugs, radiation therapy, or different viruses. Okay? This is important because if this is present, then somebody's susceptibility to fungal infections, to viral illnesses or malignancies is going to be heightened. All right, monocytosis. This is going to be an increase in your monocytes. Typically, this is going to be seen in more chronic type infections, tuberculosis, endocarditis, things like that. Okay? You'll also see it very commonly in inflammatory disorders, so rheumatoid arthritis, lupus, those types of conditions as well. The monocytes are able to transform into leukemia, okay? It is not as common, but that can occur from this as well. Leukocytosis, this is gonna be an increase in your blood leukocytes, okay? This typically occurs after a very acute hemorrhage, okay? Usually within 1 to 2 hours, and is going to be more severe if the hemorrhage is internal rather than external, okay? So here, you're gonna have a white blood cell count greater than 10,000 per square millimeter. There's going to be a leukoid reaction signified by greater than 50,000. And this is going to be present and indicate a very severe underlying disease process, okay? So in terms of symptoms, they will likely have a fever, a severe headache, shortness of breath, infection type symptoms, and inflammation or very severe tissue trauma, okay? Treatment here is going to be managing the symptoms, focusing on whatever the underlying issue is, and trying to control any infections that are present. Okay, next we have leukemia. This is going to be more a malignant disease that involves the white blood cells. Okay, so specifically in the bone marrow formation, the lymphatic tissues, the white blood cells will multiply kind of uncontrollably. Okay, and then those white blood cells will be released into the blood circulation. The onset for leukemia is very typically abrupt. Okay. Let's see. There are 4 major types of leukemia. Okay, so you have acute lymphocytic leukemia. This is something that develops early with more immature forms of lymphocytes. And you'll see this more in pediatric patients, okay? It can occur in adults, but it is more common in kids. There is chronic lymphocytic leukemia. So on the other end of that, this is going to be more common in older individuals, okay? This is most often asymptomatic, okay? But it is technically the most common form of leukemia. So that will originate directly in the lymphatic tissue. Myelogenous leukemia, again, is more common in older adults. That is going to originate within the bone marrow. Okay. That type is more commonly following a different type of cancer. So usually after someone has gone through radiation or chemotherapy for a different type of cancer, that then develops. Okay, and then there's also chronic myelogenous leukemia. So again, this is still developing within the bone marrow. But it's when a stem cell has then been malignantly transformed. Okay, so again, 4 types of leukemia here. When it is acute, there is usually some type of infection that is present that is then unresponsive to treatment. And that's kind of how they figure out this is going on. A lot of different symptoms can occur with this. So you have a lot of infections, anemia, hemorrhaging, a lot of internal hemorrhaging, pain, bone pain, fatigue, weakness, fever, a lot of different kind of stuff. In terms of diagnosis, that is going to be made through the CBC and then looking at a blood smear as well. Okay, that blood smear will show the immature leukocytes as well as the increased number of white blood cells. In order to actually confirm the diagnosis, they would have to undergo a bone marrow biopsy. All right, last section here we have is blood clotting disorders, okay? So this could be sudden or after excessive bleeding or minor trauma, okay? Clotting, we know, is going to be stimulated by the release of thromboplastin, okay? That lines the blood vessels, and it's going to convert it into the active form of thrombin. That acts on your fibrogen, which is then converted to fibrin, okay? So basically, that fibrin turns into like a web-like of red blood cells to form the platelet plug, okay? That is what ultimately will stop the flow of blood. Okay, so you're making your own blood clot, basically. Okay, so in terms of disorders, we have thrombocytopenia. With this condition, you have a decrease in platelets. So that, of course, if we don't have those platelets, that process is not going to occur, and you're not going to get that normal blood clotting. This does not have a known cause, okay, but you will see an excessive amount of bleeding, okay, because you're not getting that clot formation. In terms of diagnosis, this is going to be made through patient history. They're going to look at the CBC, look at the platelet count, and then there's some other bleeding tests that they could do in addition to this. For treatment, they could require a transfusion if necessary, vitamin K supplement, and then just education to try to avoid trauma as best as they can. There's also disseminated intravascular coagulation. This is a life-threatening condition, again, where there is an excessive amount of bleeding and clotting. So this can lead to hemorrhaging, hypotension, or shock, okay? Hemorrhage is typically the primary sign that you'll see with these individuals. Because of the life-threatening nature of it, treatment here is very difficult. They have to figure out what the underlying cause of it is in order to directly intervene at that level. But most often, when the bleeding is severe, they're gonna have to go through transfusions, replacement therapy, and get more plasma and platelets into their body. Next, we have hemophilia. So we have hemophilia A, hemophilia B. Hemophilia A is going to be a deficit or abnormality of the clotting factor 7. Okay, so that is going to manifest in men, but is carried by women. Okay, and then hemophilia B is going to look exactly similar, but this is an X-linked recessive trait that is related to either mutation, deletion, inversion from the genes. Okay, so symptoms here, they're going to have a lot of bleeding episodes throughout their life. Very minor trauma, you're not going to get that clotting to occur. So even with minor trauma, there's going to be a lot of bleeding. Okay. They're going to look at blood tests for diagnosis. These individuals, it's important to encourage them to avoid use of blood thinners and aspirin. Okay, aspirin is a blood thinner. Von Willebrand's disease. This is going to be, again, a hereditary deficiency of that factor where you're getting platelet dysfunction, okay? So again, you have a lot of bleeding with very mild trauma, okay? So von Willebrand's factor is a protein that actually helps to clot the blood. So if that is deficient, you're not getting that blood clot. Okay. Treatment here is if the patient is actively bleeding or undergoing surgery, they can use an infusion of the von Willebrand's factor to help that clotting. And that's usually the most helpful thing that they can do in this situation. Okay. And then the last slide is just a little bit of information on aspirin and NSAIDs. So again, aspirin is going to act like a blood thinner. Okay. It's encouraged if people have, some type of cardiac pathology where they're not getting the blood flow, but on the other end, if you're having blood clotting diseases or disorders, then that can also be detrimental to the clotting ability as well. So typically before surgeries, you want to avoid these types of things so the blood is able to clot while they're in surgery. But again, that information needs to come from the doctor as well. But typically that's part of the education that goes into any type of preoperative status. Okay. All right, I know that was a lot of information today. Hopefully a little bit of it was at least terms you've heard before. Like I said at the beginning of class, I know Camelia came in late, so at the beginning I said that I'll review the schedule for the rest of the semester this afternoon. I'll send that out to you guys once it's completed. But again, I'm going to take peripheral nervous system, central nervous system out of this class, and we'll just put that in anatomy. So hopefully we'll just be, pushed back a week for this unit and then normalize from there. Sound good?
So our PAP test would be the 21st.
Whatever the week after was
From
our
the 14th.
Yeah,
And
because we
then-
still have to go through respiratory next week.
So it
the
would be
week after that.
14, 15, 16, 17, and 18.
I have more, okay. Any other questions? Okay, all right, well, let me know